We described the hepatitis C virus life cycle and looked at the mechanism of action of direct-acting antiviral agents. We also looked at recommendations from AASLD IDSA guidelines for genotype 1, 2, and 3. Now the next learning objective is given on Hep C patients, evaluate and manage drug-drug interactions. So as you can see, all of these direct-acting agents are substrates of P-glycoprotein. So that's something that stands out for these agents. Voxilapravir, which is a protease inhibitor, is a substrate of CYP3A. You will see that in general, protease inhibitors are categorically substrates of CYP3A. So keep that in mind. And then with ledepasphere and velpatasvir specifically, they also inhibit P-glycoprotein. So this can affect other drug concentrations. So, because they inhibit P-glycoprotein. And then pretty much most of these are eliminated through the feces, except for sofosbuvir, which is 80% secreted in the urine. Again, we can see that most of these are substrates of P-glycoprotein. On the right-hand side, you can see the protease inhibitors, so NS3-4A protease inhibitors, and these are substrates of CYP3A4. Elbasvir is also a substrate of CYP3A, and pibrentasvir, paritaprevir, and glecaprevir also inhibit P-glycoprotein. So I'm just showing you this so you will see some of the drug interactions that occur with these agents. Now here are some of the common inhibitors of P-glycoprotein, just for your reference. You don't have to memorize this list, but you can refer to it to see if there is a drug interaction. And these inducers are commonly encountered in practice, so it's really good to know these. So P-glycoprotein inducers. So anytime you see these agents, it's always a good idea to run a drug interaction check to make sure that there is no interaction with other drugs. Now let's take a look at Harvoni or sofosbuvir ledepasphere. Ledepasphere needs an acidic environment for absorption. Therefore, there are drug interactions when it comes to acid suppressive agents. So antacids should actually be avoided within 4 hours of administering sofosbuvir ledepasphere. Proton pump inhibitors, it's best to avoid it, but if someone has to have it, it's recommended to give it simultaneously. So by the time the PPI kicks in, hopefully ledepasphere has already been absorbed. And it's best to actually give it with food if this interaction is to happen. And H2 receptor antagonists can actually be given simultaneously or separated 12 hours apart. And of course, for most patients with normal renal function, H2 receptor antagonists are actually given every 12 hours. So that makes it impossible to separate by 12 hours. For those patients that require renal adjustment, H2 receptor antagonists are administered once a day. So for those patients, you can actually separate by 12 hours. Also with the PPI, the interaction is dose dependent. So patients who are on higher doses of PPI, so for example, people with GI bleed, recent GI bleed who are on a PPI twice a day, they're more likely to have the interactions because of the stronger acid suppression. Now note that with these drug interactions, some of them are actually contraindications and some of them are actually not a contraindication, they're just not recommended. So for example, Rifampin and St. John's wort, they're actually P-glycoprotein inducers, and their concomitant use with Harvoni is not recommended, along with some other agents. When it comes to statins, rosuvastatin is not recommended. It's okay to use atorvastatin, which you will most commonly see in practice. And for those patients, you should just monitor for symptoms of myopathy. Now, when it comes to amiodarone, there's been a drug interaction specifically with sofosbuvir. So there's been serious symptomatic bradycardia case reports, including fatality. So because of that, it's very important to monitor patients who are on amiodarone. It's best to avoid it. But if, if someone absolutely needs to have amiodarone, it's best to explore options that do not require sofosbuvir. But again, this is not a contraindication. So if the patient does need to be on both of these agents, then it's important to have regular cardiac monitoring in these patients. With the Vicera pack, because it's a boosted regimen with ritonavir, there are many drug interactions. In fact, there are a few that are contraindicated. So these 3 statins are actually substrates of CYP3A enzyme. So because ritonavir is a strong CYP3A inhibitor, they're actually contraindicated. And because of this pharmacokinetic booster, there are many more interactions that are listed in the package insert. So I refer you to the package insert. With Zapatir or Elbasvir, Grazoprevir, strong CYP3A inducers are actually contraindicated, along with some HIV regimens that we will discuss later. With Velpatasvir, it also requires an acidic environment for absorption, so the same recommendations that apply to Ledipasvir also apply to Velpatasvir. And of course, Amiodarone interacts with sofosbuvir. When we have Vosevi, basically it has the 2 agents from Epclusa and it just adds voxilaprevir to it. So all interactions from Epclusa apply to Vosevi plus more. So voxilaprevir is a protease inhibitor. So Rifampin is a strong inducer of CYP3A and is actually contraindicated. For Maviret, Rifampin is contraindicated. Etazanavir is a HIV protease inhibitor, and that one specifically is contraindicated, whereas other HIV protease inhibitors are just not recommended. And one interaction that exists with all direct-acting antiviral agents is the warfarin. So because all of them can affect warfarin, it's recommended to increase the frequency of INR monitoring. So that one is basically just managed by adjusting the dose of warfarin based on INR.